You have the floor.
Okay, thank you very much, George. Thank you very much for the kind welcome and for having me here this afternoon. I wish I could be there in person to see some familiar faces, and also because it was minus 24 degrees Celsius when I woke up this morning in Toronto. But anyway, the topic I'm going to present is looking at BC healthcare workers' exposure to hazardous drugs, a 15-year journey. So I have been working on this topic for that period of time. And in fact, it was my doctoral dissertation. So without further ado, I just want to provide a quick disclaimer that these opinions in this presentation are mine and mine only and not that of my employer. As George mentioned, I am formally trained as an occupational hygienist and I got my certifications in health and safety and then I pursued my PhD. And since 2012, I've had an academic appointment with Toronto Metropolitan University. If you are interested in learning about some of the work that I've done, please feel free to take a look at this Google Scholar link that's on this slide. So what we're going to do this afternoon for about 45 minutes or so, we're going to look at what hazardous drugs are all about. Then I'm going to talk briefly about some of the health effects associated with occupational exposure. Then I'm going to provide an overview of some of the ways that researchers have examined exposure to this particular hazard. And then after that, I will review the variety of different articles or projects that I've been involved with throughout the last 15 years. And then briefly, for those of you who work in hospitals where hazardous drugs are handled, or you've know someone who works in a hospital where they handle hazardous drugs, just want to provide an overview of some of the controls that can be implemented to reduce the risk. And then we'll open up the floor for Q&A. So what are hazardous drugs? So these are different agents in the healthcare setting that are designated as either cytotoxic, such or cell killing, or antineoplastic, which is anti-cancer. And these are relatively toxic agents. They are used primarily for the treatment of cancer, but some drugs are used in other non-cancerous diseases, such as multiple sclerosis. Um, at this moment in time, there's estimated to be about 200 different hazardous drugs that are currently being used in healthcare settings. But there are new developments in drug technology, so there are new drugs being developed on a regular basis. These drugs are inherently toxic. However, when it comes to the patient who is suffering from a disease, the benefits far outweigh the risks. This cannot be said for the workers who are inadvertently exposed to these hazardous drugs, and that's because of their non-selective mode of action, meaning that they target both normal cells as well as the cancer cells. And this issue about occupational exposure first became known in the 1970s. And that's because a number of workers were reporting different health effects. And I'm going to go through those various health effects later on, but these health effects could be either acute or chronic health effects. Okay, so short-term or long-term health effects. In terms of acute health effects, and by the way, all these articles I've tried to find a systematic reviews or meta-analysis so that you know that this is not just an individual study. There was a really good review that was done by Connor and McDermott, and they're looking primarily at nurses with regards to the acute health effects, and they reported a variety of different ailments, hair loss, headaches, acute irritation, etc. But the more pressing concern are the chronic health effects. Okay, and one of them is DNA damage. And in this meta-analysis, they found that there was cytogenetic effects, and this was statistically significant based on the confidence interval there. Another study found that there was a relationship between exposure to antineoplastic drugs and increases in chromosomal aberrations amongst healthcare workers. Other chronic health effects are cancer and reproductive toxicities. So, in terms of cancer, the type of cancer was breast cancer. And this was also statistically significant where they found a relative risk of 1.83. And then this is somewhat dated. It's from 1995, but Sissink was one of the leading researchers looking at healthcare workers' exposure and hazardous drugs. And he reported an increased excess in the number of cases of cancer. And it was uh, between 1.4 to 10 per million workers. So exposure to hazardous drugs leads to excess number of cases amongst the exposed. In terms of reproductive health effects, spontaneous abortions has been reported, as well as individuals have been found to be longer to conceive. And a more recent systematic review confirmed both of those reports that I have listed earlier. So we'll go to our first poll question. Um, which of the following reproductive health effects are believed to be associated with occupational exposure to antineoplastic drugs? Is it A, spontaneous abortions, B, difficulty conceiving, C, miscarriages, D, congenital anomalies, or E, all of the above?
You can go ahead, Chun.
Oh, okay. Sorry, I thought Donald was doing this. Okay, let's just stop sharing this then. So most of you said all of the above, and that is correct. Okay, excellent. So let's share the results there. You should be able to see that. So again, most of you got the correct answer of E, that it is all of the above. All right. So moving on then, I mentioned that some of these agents may lead to cancer. And so this table lists the different type of drugs on the left-hand side, their carcinogenic group classification, and then what that classification means. So you can see that CP or cyclophosphamide in the top side is a group one. So these are known human carcinogens. And then moving down the list, you've got some probable carcinogens as well as possible carcinogens. CP or cyclophosphamide is some term or the drug that you should be familiar with for the rest of this presentation because not only is it handled quite often, but it's the drug of typically examined most often in the literature. So for most of the work that I'll be discussing, CP is one of the drugs that was examined. And again, it is a known human carcinogen. In terms of how a worker can be exposed to hazardous drugs, the literature has indicated that the main route of exposure is dermal or skin contact. And there's two different ways that that can happen. So on the left-hand side, you see what's known as direct contact, and that's where the healthcare worker would touch the drug vials, the drug bags directly. And this would be mainly during drug preparation in the pharmacy or drug administration, which would be the nursing units. And then on the right-hand side, you can see indirect contact is also possible. So this would be where an individual would touch a drug-contaminated surfaces. So typically without wearing gloves, they would touch a contaminated surfaces. And all the red arrows that you see in that image are potentially contaminated areas in terms of what's been found in the literature. And we'll talk about that a bit more later on. And this can happen during any part of the hospital medication circuit. That is known as the life cycle of a drug from delivery to waste disposal. And we'll talk about that a bit more. Okay. Other routes of exposure that are believed to be possible is inhalation as well as accidental ingestion. So for that latter part, it means that someone hasn't washed their hands properly, and therefore, when they go and break and have a drink or consume something, they may accidentally ingest the residual hazard drug that's on their hands. Okay. So in terms of the future outlook, numerous different sources have indicated that the number of new cancer cases in Canada is expected to rise over time. And that's because as the population ages, they're more likely to develop these different types of cancers. And as a result, that means that there's going to be increased use of hazardous drugs used to treat these individuals that do have cancer. Okay. Another thing that's important to note is that these drugs are also being used outside of acute care settings. So, home care and veterinary clinics are two of the settings whereby these hazardous drugs are being used. So, what does that mean? Well, it's a concern right now because of the fact that we have identified contamination and we've identified that there's an increased risk to health effects as a result of exposure. And so it will also be of concern moving forward because of the number of cancer cases increasing. With regards to the number of healthcare workers at risk, typically those individuals who prepare and administer drugs, so the pharmacy folks as well as the oncology nursing folks, they are certainly at risk. But any individual who works in those areas where these drugs are found or are handled are also at risk of exposure, and I'll talk about that a bit later on. In the US, there's approximately 8 million individuals that are considered at risk of exposure. And here in Canada, CareX has estimated that it's about 79,000 Canadians are occupationally exposed. Um, as you'll see with the studies that I'll be presenting later on, anyone that's working in the hospital medication circuit is at risk of exposure. And so, again, what's this hospital medication circuit? It's where the drug travels throughout the hospital. So you start with the drugs being received, typically in the receiving department. Then it has to be transported to pharmacy where it's prepared for the patient. Step three is pharmacy verification, and this is where an individual does a check and balance to make sure it's the right drug and the right dosage for the patient. Number four is the fact that once it's prepared in the pharmacy, it has to be transported or delivered to the patient care area. So, not all hospitals are designed the same way in the sense that the pharmacy is immediately adjacent to the drug administration ward. It could be quite a distance away, so it has to be transported. And then step five is where the drugs are being administered to the patient. And then lastly is housekeeping or waste disposal, whereby the waste products has to be removed. And then housekeeping, they have to clean the various surfaces whereby these drugs might have contacted. So some of you might be asking, well, are there occupational exposure limits? The short answer is no, there are no occupational exposure limits. Nothing published by ACGIH, nothing by OSHA. And so what's the direction most people are going towards are hygienic guidance values or HGVs. And these have been suggested in a lot of different countries, not here in Canada or the US for that matter. But basically, these are performance metrics whereby you're trying to strive for these HGVs in terms of contamination levels. And that means that if you are below these HGVs, it means that you've done a pretty good job of minimizing the contamination levels. It is not health-based, so it doesn't mean that, like in OEL, if you exceed the HGV, you're at greater risk of developing a health effect. That's not the case. It's just a matter of performance. And if you can strive for that HGV or lower, that means you're doing a pretty good job of keeping the contamination levels at a what they consider an acceptable level. These are guidance values, and so that means that they're not enforceable and they only apply to surface contamination. So I mentioned that there's other routes of exposure, so they don't necessarily apply to those other routes. So because there's no exposure limits, all of us in the occupational health and safety world will know that it's that we have to exercise the precautionary principle of ALARP, which is as low as reasonably practicable. So that's what we're trying to do in terms of keeping the exposure or contamination levels as low as possible. Okay. So I'm going to let people digest a little bit and ask any questions at this moment in time about hazardous drugs and the risk of exposure, et cetera, before we go on to the literature. So if there's any questions, I will gladly take them at this moment in time. And George, I don't know if you're mediating.
Yes, I am. We
Okay.
generally wait till the end of the
Okay. All right.
presentation.
That's fine. Okay. So if that's the case, let's move on. So how do we go about assessing exposure or contamination? Um, it is hazardous drugs are chemical agents, but unfortunately, unlike other chemical agents that are out there like lead and benzene, there's no standard exposure assessment method available. In the literature, there have been a variety of different methods that people have looked at in order to determine the exposure levels. So first is determining the surface contamination through wipe sampling. And that's probably the most common one in all the studies, simply because it's non-invasive, it's relatively inexpensive compared to the other methods I'm going to talk about. There's also dermal contamination, which is very similar to surface contamination wipes, but rather than wiping the surface, you would wipe the individual's hands. In some cases, I've actually taken the gloves and then did some digestion of the gloves to determine the contamination levels of the gloves themselves. There's urinary contamination, where you collect urine samples from workers and then you send that off to lab for quantification purposes. And then lastly is genotoxicity assays. So you're looking at DNA damage or other genetic markers to determine if someone was exposed to hazardous drugs. There's a variety of different papers that have been published that are great summaries of all the different methods available. And I won't go through them all, but I will tell you what we did for our studies. Okay. So as I mentioned, surface contamination is probably the most common method to determine the level of hazardous drugs found on different work surfaces. The other term is environmental monitoring. And using surface wipes is beneficial for a variety of different reasons. So first of all, you can evaluate how people work. And so again, I mentioned about those hygienic guidance values. You want to see how well people are striving towards a hygienic value. So if they're above, perhaps they are working in a quote unquote sloppy fashion, or they might have had a spill and didn't know it. And so that's one of the reasons why we do the surface wipe sampling. You might want to evaluate the effectiveness of control measures. So there is an engineering control, which we'll talk about later on. And you do wipe sampling before you implement the intervention, and then you take additional wipe samples afterwards to see whether or not there's a difference. And assuming that there's a reduction post implementation, therefore, that's your way to evaluate how effective that intervention is. And then lastly, to look at the risk of exposure for healthcare workers. Like I said, there is no occupational exposure limit, but there have been a variety of different values that have been published out there in terms of guidance that we typically use to compare to. So, in terms of surface contamination in hospitals, um, and then more locally within BC, we did find that surface contamination was found throughout the hospital medication circuit. So all the different stages I talked about, from delivery till waste disposal, there was some detectable levels of drug contamination. It's not surprising that pharmacy is the most contaminated department. That is where the drugs are prepared. And there are different surfaces and objects that have been contaminated. So if you look we go to this slide. This is the pharmacy area. I won't go through everything that's listed on the right-hand side, but you can see these images of different objects and surfaces which have had detectable levels of hazardous drugs. So you're looking at some bins, either for transport or for storage. You're looking at communal objects like the keyboard and the tweezer there. You're looking at carts. You're looking at fridge handles. And then in terms of those areas within the drug administration or nursing units that have potential contamination, everywhere with this checkbox is, a check mark is potentially contaminated. So here you're looking at the patient chair, You're looking at the waste disposal container. You're looking at the floor, and then the clipboard, and then the IV pump. So again, a variety of different surfaces have demonstrated detectable levels of hazardous drugs in the past. So when you think about that, especially for the nursing unit, when now that you have detectable levels that are found in patient areas, so not this is no longer just an isolated occupational health issue. This is now a possible public health issue whereby you have the patients potentially at risk of exposure, plus also any visitors. Okay. And so if you've ever been to a hospital, they don't restrict these areas necessarily. So you could have a large number of people coming into the nursing unit, and therefore they might be at risk of exposure. Again, they are not wearing personal protective equipment. They may not be exercising hand hygiene to the same degree as a healthcare worker. So something to think about that. Okay, next poll question. Which of the following surfaces have not had reported levels of hazardous drug contamination? Is it A, door handles, B, IV pump, C, computer keyboard or mouse, D, the floor, or E, all of the above surfaces have been found to have drug contamination? Okay, give it a few more seconds here. Okay, I don't see. Oop. Oh, no, we do. Sorry. All right, so let's see the results. Most of you said all of the above, and that is correct. So every one of these surfaces have had detectable levels reported in the literature. And so some of these things are items that you probably wouldn't think about, like the computer keyboard or door handles, but unfortunately, they have found contamination with hazardous drugs. Okay. So we won't take questions. So we're gonna move on. So now I'm gonna go to the part where I'll be summarizing the different studies that I've been a part of. The first thing that we did was a pilot study. This was just to look at whether or not workers in the Lower Mainland were likely to have uh, residual levels of hazardous drugs on their skin. So we had six hospital pharmacy participate in the study. We took three workers from each of these pharmacies. I already mentioned how we go about wiping surfaces. So in terms of what we did here was that we wiped the individual's hands, and then we're looking at cyclophosphamide, methotrexate, two of the most common hazardous drugs that are out there. At 50% of sites, we found at least one sample was above the limit of detection. And we found that cyclophosphamide was found more often than methotrexate, but then no sample had both drugs detectable on that. So this told us that the healthcare workers within the Lower Mainland are indeed at risk of exposure to hazardous drugs. So this was our very first study. And so from that, we looked at trying to identify those job categories that might be at risk of exposure. Okay. As What we did here was that we did wipe sampling, as well as we did observations to figure out which jobs titles would traverse those different departments. Okay, so in terms of wipe sampling, we did wipe sampling of all the different hospital medication circuit stages, except for waste disposal, because at the time that was contracted out and we didn't get permission to look at waste disposal or housekeeping. But we were able to do the other departments, or stages, sorry, delivery, preparation, transport, administration. And you can see here that preparation was had the highest mean contamination level. So that was not surprising. That supports what we talked about earlier. And then in terms of the job categories that were consistently at risk of exposure, they were nurses, pharmacists, pharmacy techs, and pharmacy receivers. So if you remember the pictogram I showed you of the hospital medication circuit, these are individuals that would more likely directly handle the drugs as opposed to be exposed indirectly. In terms of the number of job categories, we found that up to 11 job categories per site may be at risk of exposure. And these are individuals that, because of their job, they're involved in the hospital medication circuit in one way or another. So you're looking at, besides the pharmacy and nurses, you're looking at unit clerks, you're looking at transport staff, yeah, there could be nutritionists, dietitians. These are all individuals that were in some way involved in the hospital medication circuit. So now we know that the number of people exposed is over and above just pharmacy and nursing folks. There may be other job titles at risk as well. In terms of the cleaning, we are looking to see how effective cleaning was. So we took samples uh, before cleaning, uh, before cleaning, and then we took samples after cleaning. So pre versus post. We looked at high touch surfaces, and then 61% of the surfaces that we sampled pre-clean were contaminated with either methotrexate or cyclophosphamide. And then post-clean, the contamination results were generally lower. And again, that's an expected result. And this was statistically significant for cyclophosphamide. However, there were some samples that appeared to have higher post-clean contamination levels, which is very surprising. And so as a result of this study, we concluded that drug contamination is common and that these cleaning protocols may not be effective to completely remove the drug contamination. So in 2013, this is one of the studies that resulted from my doctoral dissertation. So there were three different phases. Surface contamination was one, then we did dermal, and then we did urinary. So this was a much larger study in terms of sample sizes and the number of sites that were participating. So in this situation, we looked at 438 high-touch surfaces throughout the hospital medication circuit. We only looked at cyclophosphamide, but you can see that there was detectable levels with a mean concentration of 0.201 nanograms per square centimeter. There was some variability with a GST about 2.5, but you can see that based on the range that it was less than detection all the way up to 26.1 nanograms per square centimeter. Okay. Every single stage of the hospital medication circuit had detectable levels of drug contamination. And again, we confirmed that the highest was found in the drug preparation unit. Okay. What was interesting about this study is that prior to collecting the wipe samples, we asked individuals about cleaning as well as how much drug was handled. And it appeared that there's no association whatsoever. So in some cases, even though they said they handled cyclophosphamide, the wipe sample showed a very low level contamination or below detection limit, whereas other cases where they said they didn't handle CP and then it was relatively high. Same thing with cleaning. There was no apparent association with the contamination levels. So phase two of the doctoral work was looking at contamination on workers' hands. So I talked about how we collected those wipe samples already, so I won't repeat that. We had 225 individuals that were participating in the study. 20% of the samples were found to be greater than the limited detection for cyclophosphamide. We had a mean concentration of 0.36, and then there was the range was less than limited detection to 22.8 nanograms per wipe. Okay. Similar to the fact that we found drug contamination on surfaces at all stages of the hospital medication circuit, we found that all job categories that were evaluated had detectable levels of drug contamination. And interestingly enough, that those individuals who worked in the drug administration unit but were not responsible for drug administration directly. So these were essentially people that were not nurses. They had the highest proportion of samples greater than LOD. Okay. And then the highest recorded concentration for the entire study was from a worker who had no known contact of cyclophosphamide on their work shift. So again, some very interesting findings that we still don't know how to explain these, but it was just something to highlight that there doesn't seem to be any sort of association between handling cyclophosphamide and the contamination levels on workers' hands. Okay. Phase three looked at urinary contamination. So in this instance, we collected 24-hour samples from individuals, and 55% of the samples had detectable levels. Okay. The mean concentration was found to be 0.156, and then the GST was 3.8. So some variability, which is not surprising because we are talking about urine samples. And then the range was less than detection limit to 2.37 nanograms per mil. Okay. Uh, just like with the dermal wipe samples, every job category that we evaluated had some detectable levels of urine. And unit clerks in this case had the highest average level. Okay. Um, in terms of the workers who were in the drug administration unit, but were not directly involved in drug administration, had the largest proportion of samples greater than the limit of detection. So again, no correlation between the urinary contamination levels and contact with cyclophosphamide during their shift. So again, a very peculiar finding. So next poll question. Which of the following healthcare job categories are at risk of exposure to hazardous drugs? A, nurses, B, pharmacists, C, transport staff, D, housekeepers, or E, all of the above. Okay, a few more seconds.
That should do.
Okay. All right. We'll end the poll here. So most of you said all of the above, and that is correct. So every single job category that's listed here had some detectable levels of drug found in their hands or in their urine. Okay. So we'll stop sharing. So moving on then. So as I mentioned, the previous studies only looked at cyclophosphamide. So it was important to think about um, making improvements to the analytical methods so that it could detect more than cyclophosphamide. And the reason for this is that you get a much more accurate idea of the exposure risk because workers don't just handle cyclophosphamide. There's a concoction of drugs, so a variety of different drugs may be used by the worker or at least by the site too. And so that's why it's important to have a method that could simultaneously detect a variety of different drug products. And so this one developed a method that could look at six different drugs listed here. We analyzed them using high performance liquid chromatography, tandem mass spectrometry, or HPLC MSMS. This is the gold standard, so that means that every other study uses this particular method. And the LODs were improved over some previous studies, or they're comparable to previous studies. So that was a nice little achievement there. And so Maddie Geronimo was the one who led this. And then moving on to 2017, we further refined this analytical method. So rather than the six drugs, you're looking at 10 drugs, so much more accurate assessment of variety of different drugs here. This was validated that there's good recoveries as well as sensitivity values and relatively short runtime, which is important when you have a large number of samples that were collected. And this new method was really great in terms of the limit of detection that we were able to get down to the picogram per centimeter squared value, whereas the other ones were at the nanogram level. And this is important because, again, of a LARP, we're trying to get exposures as low as reasonably practicable. And so we have a better idea as to the contamination levels if we can get to the picogram levels. Okay. In 2020, this was led by George. What we wanted to do here was to help healthcare organizations facilitate surface wipe sampling. And the reason being for that is that it would be expensive and some coordination is involved in order to have either the health and safety person for the hospital or a research person to go out to hospital to collect wipe samples. So we figured why not try to make it easier and help facilitate the wipe sample collection. And so we decided to put together a kit. And in this kit were the list of items that need to be required for collection, like the wipes themselves, the template to delineate the wipe surface area, measuring tape if you had to take measurements to collect the surface area, and then various instructions to allow the user to know how to go about collecting these wipe samples. Okay, and then we also tied it hand in hand with that previous analytical method I talked about earlier, where we were able to quantify 10 drugs. And we put together what's known as the DESC, which is the Drug Environmental Sampling Kit. And we asked these users how they felt about it. Individuals were typically satisfied with the wipe sample toolkit. And then we also wanted to make sure that it was user friendly, which they said it was. Again, it was to help facilities facilitate wipe sampling so that they could do the environmental monitoring if they needed to. Moving on, I conducted a scoping review of biological monitoring. I did mention that we did take urinary samples for part of my doctoral work, but it's not being done routinely. And so I wanted to know through the review what is being done and what did people find about this. So the beauty of doing biological monitoring, as many of you know, is that it does assess all routes of exposure. When you're doing wipe sampling, you're only doing dermal. I talked about the fact that inhalation as well as accidental ingestion may be a route of exposure. So by collecting biological specimens, you can capture all routes of exposure. And this is not currently done, even though it's a recommendation. So we want to know whether or not there was any value in going about doing biological monitoring for hazardous drugs. The scoping review looked at papers between '05 and 2020. 39 articles were included. And most of the studies that we looked at did identify that urine samples had detectable levels of hazardous drugs. And those that were case control studies actually found that the levels were statistically significant between the cases and controls. However, there is no exposure limit. There is no standardized sampling method. Some did spot sampling. Some individuals collected at a certain time during the week, and then some people collected 24-hour samples. So there's no standardized approach. So which one is best? Can't really say. And then there's no correlation between the contamination levels and the health effects. And then there's also cost considerations. You need a lot more specimens jars if you're going to collect for 24 hours. And also, it's the preparation involved is much greater, and then therefore that adds to the cost considerations. Then in 2023, I was approached by a private company to test the novel qualitative surface wipe method. And essentially, this is a positive or negative detection. And if it proved to be effective, that would mean that individual organizations could take surface wipes and get real-time results. So that saves in terms of sending it off to a lab and then waiting for results. And we know that things can happen between the time that you get the results and what happened when it was collected. So there could have been cleaning or there could have been spill, et cetera, et cetera. So we wanted to test this qualitative device with the traditional wipe sampling that I've been talking about. We had known drug contamination on the plates, and we would test wipe one plate with a traditional wipe the other one with this novel method to see how they correlated. And so this is a single drug detection device, so it can only do methotrexate or cyclophosphamide. There's other new drugs available now that it can detect, but it's only a single drug, so we had to do repeat testing for methotrexate and cyclophosphamide. Basically, it worked well at all concentrations for methotrexate, but for cyclophosphamide, that was not the case. It could not detect all samples. And so we basically concluded that this is a possible tool to use, but only at higher levels of drug contamination, not necessarily at some of the lower levels that we have seen of late in terms of surface contamination levels. Okay. And then last year, we're looking at the adoption of engineering controls. And the most common type of engineering control is known as a closed system drug transfer device. And this essentially minimizes the amount of surface contamination. And so we wanted to know how people felt about bringing this new device into practice because it is a change in how they go about doing things. We did contamination testing over 3 time periods prior to implementation, 1 month post, and then 5 months after as well to see what the drug contamination levels were like. And we were very pleased to know that uh, there was a significant reduction between T naught and T1, as well as from T1 to T2. And then we also asked the healthcare workers how they felt, mainly positive comments in terms of adopting this into practice. However, they felt that training could be offered in a variety of ways, in person, video, maybe some observation, as well as making sure that there was ongoing communication about this new device coming in. Then, most recently, I just submitted the report to WorkSafe earlier this week. We're trying to figure out if these occupational exposure judgment tools would be feasible to interpret the contamination results. And the reason for that is that for those of you who are aware of these exposure judgment tools, it takes out the subjectivity of it because it models the probability of overexposure. Okay. And so even if you have small sample sizes, it can do that. And that's important because collecting a large number of samples is very costly, especially for our public healthcare system. And again, it's not just the cost of analysis, but also the time associated with that. So if these exposure judgment tools like ExpoStats is able to facilitate the interpretation, that's what we wanted to determine. And so what we did was that we collected these wipe samples and we characterized the data, and unfortunately, 90% were not detectable. And so because of this, we could not use ExpoStats. So we did mainly descriptive statistics. So the median values of the contamination is relatively low, but there were some maximum values that were still of concern, and therefore our recommendation is to have routine environmental monitoring. Okay. So last question, true or false? There is a correlation between surface contamination levels and workers' urinary contamination levels. Is this A, true, or B, false? Okay, a few more seconds and we'll close the poll. Okay, we're going to end it here. About three-quarters of you said true, and then a quarter of you said false. Uh, the actual answer is false. There is no correlation. So again, you could have high contamination levels and people have low urinary contamination levels. Vice versa, you can have low contamination levels and then some people have higher urinary contamination. There's no rhyme or reason that we can figure out at this time why that is the case. So the answer to this is false. There's no correlation. Okay. So some of the challenges at this moment in time, the mechanism of spread is still unknown. We don't know how the drugs are getting transferred. Is it because people are touching an area that's highly contaminated and then touching an area that's not contaminated? Is it cleaning, which is causing it to spread? We don't quite know what's causing that. There's no safe threshold, so there's no occupational exposure limit, so we don't know what people or organizations should be striving towards. Um, I already mentioned this, but healthcare workers are exposed to more than one drug at a time. So that becomes a problem because you have to try to assess for their entire drug regimen that might be exposed to. And then the OELs are for an individual drug. So how do you deal with multiple exposures? How surface contamination relates, we're still not sure about that. There might be issues with training and PPE usage. We know compliance with PPE is a huge problem in industry in general. So we're not sure how well people comply with this specifically for hazardous drugs. I already mentioned there's cost considerations. And then lastly, there's no standardized cleaning protocols that are in place. So in terms of controls, so obviously you want to train your workers about how they might be exposed and when, during what tasks or what procedures. Okay. Labeling is very important, not only the drugs, but also the containers, and making sure that PPE is worn. And this will vary depending on task. If a pharmacist is just checking the drug products, they might just need gloves. But on the right-hand side, you see a nurse that's administering, they have to wear a larger number of person protective equipment. Okay. In order to know if people are exposed, it's important to make sure that you have a culture where you report all exposure incidents and just like any other chemical hazard, make sure that proper hand hygiene is exercised. In terms of surface cleaning, I mentioned that it's not standardized. However, studies have indicated that deactivating, decontamination, cleaning, and disinfection are beneficial because this multi-wipe process is found to reduce the surface contamination levels. And then in terms of routine environment monitoring, basically all these individuals have indicated that routine monitoring is beneficial, and that's one of the reasons why we recommended that as part of our last study to make sure that you can keep track of the contamination levels. Okay, so take-home message, surface contamination is extremely prevalent across the hospital medication circuit. There's a potential for a large number of different healthcare workers. Anyone that's involved in the hospital medication circuit is at risk of exposure, so it's not just nurses and pharmacy staff. Um, Good news, over time, the surface contamination levels have reduced, but some of those higher outliers are relatively high, and so it's a concern because they are above the thresholds. And with our data set anyway, we couldn't use exposure judgment tools. Maybe if we had a different data set, we could, but I wouldn't rely on that at this moment in time. Looking at dermal and urinary samples has limited benefits because of basically the cost benefit, what you gain of that. And ultimately, to reduce contamination levels, the recommendation here is to adhere to safe work practices and the exposure control plan. However, it doesn't appear that we can completely eliminate the risk of exposure. Okay. Variety of different references. You'll be getting the slide deck soon. So if you want to learn more, please feel free to take a look at that. And that's the conclusion of my presentation. I'm here, we've got about 10 minutes or so for questions. So if you have any more questions, please feel free to ask. Thank you.